Let me test. Just this has sound.
Okay, so good morning. I'm Deependra. I'm a PhD student at NTNU Norway, and my work is about data visualization. So the work consists of visualizing patient trajectories and disorder co-occurrence in child and adolescents mental health. So the area that I work on is basically child and adolescents mental health. In short, it is called CAMHS. So I will be using that phrase quite a lot. And we have a diverse team with people in USA as well as different universities and companies in Norway. So let's dig into it. So the problem, moving towards the CAMHS in Norway, the Child and Adolescents Mental Health Service is a secondary care in which the through referrals, the children or adolescents are referred to the CAMHS. So it's a secondary or a secondary care service provider, not the primary care providers. So if any kids had any complications, they will be referred to the CAMHS. And since CAMHS has been serving in Norway for quite a long, and they have used amount of data, and they wanted to use those data to provide quality of care, to provide with the better access to the patient histories. And one of the thing is, in case of CAMHS, the co-occurring disorder, which is presence of multiple disorder at once in a patient, that's quite common in CAMHS. So taking these things into consideration, and the data in our hand, which is like 35 years of longitudinal electronic health records, the clinician wanted is to be visualized so that it can be better represented and better understood by them, to see the patient, to understand the progression of disease in patient, the episode associated with the patient, and the disorder co-occurrence. So with this problem statement and need from the clinicians, we focused on three questions. First is like, how can visualizing CAMHS patient histories and co-occurring disorder enhance clinical decision making? So the first thing was to enhance the decision making by visualizing data in such a way that they can get certain insights from it. And second was, what are the common patterns and co-occurring conditions among similar CAMHS patient? So second was about pattern mining as well as understanding the co-occurrence. And third was, how do clinicians perceive the understandability and utility of this visualization? So finally, like evaluating if these make sense to them, and if the visualization is as per the thing they needed or they wanted. So as I said before, like we had 35 years of data. Initially the data had around 22,000 patients with 30,938 episodes. So that was our initial data model. Then we further digged into and extracted those patients with all the information that we wanted. So after pre-processing, it has 19,248 patients with around 22,676 episodes. And these three criteria, the age group criteria, the gender criteria, and the presence of ADHD, which is F90 ICD code, it's a mental health disorder, the hyperactivity disorder. So based on these three criteria, we grouped patient into similar groups, and these are the distribution of patient based on these three criteria. So using that data, this was the approach that we followed. So we had the data, we clustered the data into different clusters. The optimal clusters were identified and they were clusters. And then based on those three conditions, the age group, the gender, as well as presence and absence of ADHD, the patients were grouped into 12 groups of similar patient, out of which 6 group had F90, which is ADHD, and the 6 group had no ADHD. And all of these 12 group of similar patients were plotted into patient trajectory, as well as once we had the trajectory, we further made the patient trajectory pattern by plotting all the patient records, all the history of patients. And for the patient were diagnosed F90 or ADHD, we formed the F90 co-occurrence graph to see the co-occurrence of F90 with other diagnosis codes or other diseases. So this was the overall approach. And keeping this on mind, now let's move on to the result. So first I want to show you the how does the patient trajectory looks like. So after our patient trajectory plot looks like this. So it has patient on the y-axis and it has age on the x-axis, and you see there are different colors. So each color represents the cluster data. So green is one cluster, purple is another, and the orange is another. And in each and every you see that there is a small rectangular chunk that is an episode. So here this is an episode of a patient with an ID2, and here you can see that there are patient information. F means the gender and 2 is the age of the patient on which the episode started, and this is the number of visits that patient had during that episode. And these are the this was the basically medication prescribed, and this was the diagnosis done. So in this case the patient was diagnosed F901 but no medication was given. And it shows the same patient had another episode when he was around 10, and he has another episode around 14. So this shows the progression of disease or the number of episodes the patient had encountered through his life in the CAMHS service. So this was our patient trajectory, and for each group we plotted all these patient trajectory to see what's the pattern of the episodes or the pattern in the patient in each subgroups. So a patient pattern plot looks something like this. This is just to show how it looked like. And what we did was we further analyzed those pattern plot based on the gender as well as ADHD analysis, and it showed that when you looked at the patient with ADHD and without ADHD, the female without ADHD, so the females with ADHD as well as the males with ADHD and the males without ADHD, these three ones basically, they had an increase in number of episodes till middle childhood, but then there was a sudden decline when they moved toward the teenage years. So basically middle childhood means from 6 to 12 years, and then after 12 years it was teenage year. So that pattern was seen in those three categories. Whereas in case of females with ADHD, which is this graph, they had a steady increase in number of episodes till the teenage years. And by this the implication was middle childhood seems to be more crucial for the intervention when it comes to child and adolescent. So it seems like most of the problematic diagnoses are especially seen during the middle childhood year. Hence that's a crucial age for intervention, especially when it comes to ADHD as well as other diseases, thus requiring continuous monitoring till the teenage years from that peak point, the middle childhood. And then further on analyzing the cluster oriented analysis, because these episodes were clustered into the optimal number of clusters, which were 3. The females without ADHD and males without ADHD, their episode increased with the ages, as well as males with ADHD, their episode peaked during the middle childhood and then declined. That was in case of cluster 0 as well as cluster 2, which was shown in the red and purple color. And in case of the cluster 1, which is the green clusters, the females with ADHD episode increased with age, and females with ADHD and males with and without ADHD, their episode increased during middle childhood and then dropped. So these patterns were seen in these two different categories of episodes in the patient. And additionally, the third thing that we visualized was a co-occurrence graph. It looked like this. The central node represents the F90 is ADHD, and these all others are the co-occurring disorder with respect to these specific diagnoses. So all these are ICD codes co-occurring with that F90. And when we analyzed these co-occurrence graph, so, like the thing that we noticed was in case of males as well as in females, both learning difficulty as well as tic disorder, those were most common, and especially in case of males, the learning difficulty was common in teenager as well as middle childhood, and in case of female, it was common in teenagers. The tic disorder and disorder of social functioning was especially seen in preschoolers, and in females it was observed in middle childhood. So this was observed by analyzing those co-occurrence graph. And the notable observation were in preschoolers there were fewer CAMHS episodes, and the reason for that was because those preschoolers were getting support from other service providers like their schools or other service provider run by the government. So that's why we saw like few CAMHS episodes when the kids were preschoolers. And the Toretto syndrome was found to be mostly co-occurring with ADHD. So that was the most co-occurring disease in preschoolers. And the presence of autism spectrum disorder and reactive attachment disorder was also co-occurring with respect to the ADHD. So these were the observations seen in preschoolers. And in case of the older age group, which means like middle childhood and the teenagers, the engagement increased with CAMHS. That means like many patients had encountered when they were in middle childhood and teenagers, and the learning difficulty and social challenge was prevalent, especially in the middle childhood. And teenager female, especially when analyzed with respect to the gender, the teenager females had higher depression, self-harm, and school difficulties in comparison to the male. So this was basically an observation from the co-occurrence graph. And finally, like upon evaluating these graph with the clinicians, we basically displayed them the graph, we took their insights and then represented those information. So from the perspective of understandability, they found the visualization to be useful, and they were able to recognize patterns with the clinical observation. So they basically were able, they found this to be understandable and useful, and as well as visualizing aided them in identifying the care pattern, because the challenge they were having is they wanted to find other similar patient with similar progression of disease, and the plot was useful for them in that specific case. And other problem which they wanted to know is what is the most co-occurring disorder with respect to this specific diagnosis. So this visualization helped them to understand the co-occurring disorder, or like identify the co-occurring disorder, so that they can use when it comes to diagnosis or treating a patient. And in co-occurring disorder graph, the level 3 ICD codes, by which I means like if 3 characters were used, they were like optimal rather than displaying all the information. And like while these graphs were shown to them, or while they were using graph, they were more curious and they were like formulating their own research question. So it seems like they wanted to dig more and to kind of find more information from this kind of a visualization. However, having said that, they wanted some enhancement, like they wanted more captioning, but the thing was like including more captioning would reduce the it will like have too much information, so it would be information overload, so we didn't include that. But there is an option to include the caption as per the need. And that's now finally moving towards the conclusion. So what we did was we took the problem provided by the clinicians, the data provided by them, and visualized them, as well as evaluated the visualization through the patient trajectory plot, the trajectory pattern, and the F90 co-occurrence graph. So that's the main development part, or the main implementation in this work. And we made it in such a way that it would facilitate clinical decision making. That was the main goal, by visualizing the patient demographics as well as the care episode, because the patient can have multiple episodes. So the patient can have demographic information as well as information that is varying with respect to each episode. So all of those were visualized, and it aided in understanding the patient history as well as outcome, as well as identifying other similar patient with the similar pattern or similar information. And the plot were found to be understandable and useful to the clinicians because these were basically made for them. And other thing was, in this we basically clustered the episode into different categories. So the data was basically a machine learning pre-processed data. So these visualization shows that when it comes to understanding the machine learning analytics, these kind of plots could be useful to clarify the clustered data to the clinicians. And with that note, thanks to the funding agency, the Research Council, NTNU, as well as the Health Summit Norgay, I would love to hear any questions or any comments